Good morning. Is this a good volume? All right. I think I may stand over here so I can also see my slides and talk to you while we're getting all set up. Thanks to the Neuro Connect Alliance for organizing this event and for inviting me. Just by way of a little history, I'm a community doctor. I'm an anesthesiologist and pain management physician. I have a practice in Bowie, Maryland, and by virtue of my acquaintance with Dr. Fraser Henderson, who practices not very far from my office, I've become versed in the EDS population and then all the associated disorders. So I would say thank you to my patients for continuing to educate me and keep my brain fresh as I practice. When I was asked to speak, the question was, what would you want patients to know, was one of the things I was sort of tasked with or charged with in terms of writing a talk. And so I think I wanted to touch on maybe some sort of exciting or emerging therapies in pain management. These are things that patients are often asking me about, and this is information that maybe you can't get other places, that some physicians may know about these things and be willing to talk about them, but these are, again, sort of the newer things and the emerging things that I think are worth talking about, and I can give you a little of my experience with a few things. So you can go ahead and advance that slide. So thanks again to the Neuro Connect Alliance. I just cut and pasted this little snippet from the web page, but I really liked kind of the priorities, and I know you guys have a lobby day tomorrow, but I think I agree that common sense action for chronic pain advocacy includes money and resources for general pain research, more education to providers about weaning opioids. If you're going to be talking about this tomorrow, I would mention this article, and this is worth a Google if you're interested in the topic. It's called No Shortcuts to Safer Opioid Prescribing, written just the other week, April 24th, by several authors of the CDC guidelines, including Roger Cho, who's extremely famous in guideline writing. And basically these few authors have written an editorial in the New England Journal to say that they really feel their guidelines have been misinterpreted and applied inappropriately. So for yourselves or patients who may have had aggressive weaning or changes, I think it really gives you some ammunition, some from the people who wrote it themselves, saying, here's what we meant, and hey guys, don't overinterpret this. I could spend a whole half an hour talking about that, so we won't, but I just wanted to make sure that you had that information, because you might not know that this article even exists. It just came out, and if you're going to be talking to lawmakers and things, this is news you can use. Briefly, I wanted to mention these targets of pharmacotherapies, because we're going to, the things I wanted to introduce today are mostly pharmacologic types of treatments. And so just to briefly mention where the action of some of these substances are, so we can see that we think that local anesthetics and NSAIDs primarily have their effects out distally in nerve endings, at the dorsal root ganglion. That's where the cell body for a pain fiber lives generally. That's where local anesthetics and alpha-2 agents may work. Then that mark for the dorsal horn, where opioids, ketamine, and gabapentinoids, it's worth mentioning that because we're going to talk about ketamine, there are central effects as well, but this dorsal horn is where a lot of what we think wind up and centralization of pain may occur. Opioids have some action there. And then as well, in the central nervous system, opioids, alpha-2 agonists, TCAs being tricyclic antidepressants, and SSRIs, serotonin-specific reuptake inhibitors, that can improve what's called descending inhibition, so kind of your body's ability to turn down the volume on pain signals, that those types of medicine work in those ways. All right, next slide. So for this period of time, I thought maybe three kind of emerging therapies would be worth talking about. So Ketamine infusion is a hot topic in pain management and in depression. I'm a pain management doctor, and so the ketamine infusions that I do are primarily for pain, but there are providers out there, whether anesthesia or not, that certainly do these for treatment-resistant depression, and we've seen some great results with patients. I also have found myself using buprenorphine for pain more often. It's probably used more in Europe for acute pain than it is in the United States. In the United States, primarily Suboxone, that you might have heard of, is a medication that's used for opioid use disorder. But lower doses of buprenorphine can be effective for pain. And what I like about it is that it's not necessarily just a pill that you swallow, and we'll talk about that. And then medicinal cannabis is a super hot topic. Obviously in Maryland, dispensaries for medicinal cannabis, the legislation has been on the books for more than a year. Dispensaries have been open here in the last year, and so patients have lots of questions, and it's starting to become more accepted, frankly, to consider use of medical cannabis as part of a pain treatment plan. Next slide. So I wanted to share a result of one of my ketamine infusion patients. He's really not even somebody that I infuse. I treat him for pain management, but he's had really an amazing result, and I think this is kind of what we all hope for with a patient who undergoes a treatment like this. He's a combat veteran, working full-time, very functional, was taking what would probably be considered higher dose opioids at 120 MME, milligram morphine equivalents, prior to his infusions. He was doing poorly and missing a lot of work. He was concerned with his ability to continue to do his job. And I happened to have a friend who works at Walter Reed, and I knew that this gentleman, because he was a veteran, had maybe access to those treatments. And at Walter Reed, they are doing ketamine infusions for pain, for depression. And so I was able to refer this gentleman for treatment there. Generally, the protocols that they do are generally 500 milligram infusions at a time over a few hours, and the patient had several of those, I believe 6 initially, and then now has these booster infusions maybe every 3 months. So I still see him for pain management. He will get maybe 35 milligram oxycodone for a month. So he has that available to him, but it's not something he uses very often. So I would call him now, reducing his opioids almost to zero. He has much improved mood and quality of life. He fully acknowledges, like, wow, my mood, I feel great. It's definitely, I sought this for pain, but it's really helped my mood and depression and everything. Has a vastly improved quality of life, and while I don't think he would say that he misses zero work, he misses far less. And I think I said this here, but yeah, his pain pathology is really multiple traumas and spine surgeries. All right, next slide. So just to tell you a little about what ketamine infusion might be like. This is a graphic just depicting what a setup might be like with a recliner for safety, potential for monitors and IV poles. The studies for ketamine infusion for treatment-resistant depression, which is the main thing that ketamine infusions have been studied for, is 0.5 milligram per kilogram over 40 minutes. And so for like a 70 kilogram individual, that's going to be 35 milligrams of ketamine. And there are these kind of depression doses at this lower 0.5 milligram per kilogram level, and then patients getting them for pain, like the patient I was presenting to you a moment ago, might get up to 500 milligrams, and this is kind of a clinical decision that the physician might make, and often a first infusion might be just at this dosage, and if the patient does well with it, more might not even be necessary. I think the negatives of this treatment, it's available, but many clinics don't take insurance for it. It's generally cash pay, because it's certainly a off-label, I guess I would say, use for ketamine, and something that's sort of emerging. I would mention that there's a Facebook group called Ketamine Infusions for Better Health that is, if you're looking for patient advocacy or resources in that regard, there's a lot of discussion happening, and it's moderated by partly by a patient who's also a nurse practitioner, and I think she tries to, kind of keep the conversation in an appropriate place. That is a place you can gather some information as well. Next slide. So, ketamine treatments are going to continue to be developed. There is a newly FDA-approved treatment called Spravato, and Spravato is what's called racemic ketamine. So, the regular ketamine for anesthesia is a mix of two isomers, two forms of the same molecule. They're like mirror images, and they both do similar but not exactly the same stuff. Spravato is just one of the isomers, so it's sort of a filtered ketamine delivered intranasally. Again, it's FDA approved for treatment-resistant depression. So if you have that or know someone who has that, they might meet that criteria. It's going to be administered in a doctor's office. You're going to be monitored for a couple of hours afterward. And I guess my hope with this treatment is that it may make ketamine treatment for pain and depression more accessible. Obviously, it's a pharmaceutical. It has a high price. I don't work for them, but hopefully if it's able to, again, get the treatment out there, it may be able to assist more patients. There are a few more versions that are being investigated, including one that's a racemic, meaning both molecules, intranasal, and then another one by a different company called Synergistic Therapeutics that's making a sublingual version, so under the tongue. And presumably those will also require monitoring in an office also. We'll see once they get their studies done. Of course, some of the differences, not just among these formulations, but from these intranasal or sublingual formulations to the IV include bioavailability, that an IV infusion is basically 100% bioavailable because it's put in the bloodstream. There's also some thought that the metabolites of ketamine may confer some of the effects. In animal studies, some of those effects include making new dendritic connections, so nerves being able to talk to one another or reconnect that were not connected before, and that maybe some of these metabolites help that more. So it's unclear longer term what the differences in these couple of treatments are going to be, and hopefully we'll be studying that as well going forward. Next slide. So buprenorphine I wanted to bring up as well. I've had a couple of patients with difficulty with pain and connective tissue problems that have done well on formulations of low-dose buprenorphine. I think one of the reasons is that buprenorphine is an opioid medication. It's not a Schedule II, so meaning we think it has less abuse potential and may also have less habituation in terms of the body being as used to the medication. But the reason I guess I've seen some benefit where I've had a few EDS patients that have done well with these low doses of it is because I think that's generally taken buccally or through the skin. And so GI metabolism is avoided altogether. So for some patients that do poorly with other opioids, they may find that they can tolerate this medication better. So I have a patient who's a young female nurse. She has headaches. She has chronic neck pain after craniocervical fusion. We've done cervical medial branch blocks and even radio frequency at those adjacent levels. We started her on buprenorphine for pain more than a year ago, and she takes a very low dose, generally twice daily, and she's been able to sustain her improvements and has not needed higher doses of medication. She continues to function and work full-time. Next slide. So buprenorphine is a partial agonist, meaning a full agonist at the mu opioid receptor is something like morphine that turns it on all the way. Really gives just a go, go, go signal. versus the buprenorphine binds very tightly and avidly to a morphine receptor, to a mu opioid receptor when it has an opportunity, but it doesn't fully turn on that receptor. So that means it has a ceiling effect. It also allows the drug to be classified not as a C2 or a DEA Schedule II medication, if you've heard of that. So you can have refills on it. So for instance, for my patients that take this medication, they might not need to come but every 3 or 4 months because they can get refills on this type of medication. There's some different forms of it. One is the Butrans patch, which is now generic, but most people still use that brand name for it. It's comes in a variety of doses that are pretty low. The Belbuca buccal film, which is administered through the mouth, and comes in also a variety of strengths. And then there is a generic buprenorphine tablet that is also orally dissolvable. And all of those are potentially can work. Next slide. Finally, I wanted to speak about a medicinal cannabis patient and just the general process for medicinal cannabis in Maryland and what we've seen so far. I have started doing medicinal cannabis evaluations recently. It's not something that we started with initially, and I was speaking with some patients prior to this. I think most of us as physicians, we spend a lot of time getting our degrees and our licenses, and we're very reluctant to do things that are illegal, and that's a good thing. But because, ultimately that until cannabis is no longer Schedule I, and it is federally illegal, a lot of us are a little bit hesitant to incorporate it into our practices. So we've tried to kind of, in my practice at least, there is sort of a place for it. We do those evaluations in our same space, but there's a separate business name for it because just some of the regulations around it dictate that that's the most appropriate thing to do, so that's what we do. So I have a number of patients who do use medicinal cannabis, and I may not have done their certification. They may have come to, this patient in particular, I didn't do her cannabis certification, but I write her Lyrica and her Lidoderm, and, I keep up with some of her various pain issues, but she's, keeping me informed with regard to her progress with the cannabis work. So I have a patient who's around 60 years old. She's had significant chronic pain and need for occupational therapy over many years, many surgeries. This is not her wrist. Her wrist looks way worse than this. But she's had a number of surgeries and plates and screws and whatnot. Again, she has pharmacotherapy with Lyrica and topical lidocaine. Her cannabis formulation is an oil tincture. These are generally applied under the tongue. It keeps you from needing to smoke or inhale anything. And she has found particularly she sleeps well, and she's found herself significantly less anxious with the incorporation of this therapy into her regimen. Next slide. So just to give you that overview of what is even the process for getting certified for medicinal cannabis in Maryland, you can register at the agency, which is called the Maryland Medicinal Cannabis, MMCC. Medicinal Cannabis Commission. Sorry, I wanted to get that extra C in there for you. At the mmcc.maryland.gov. Basically, you tell them you want to be a patient, and they need a very specific photo with a white background, your ID. There's a significant period of time because there's a ton of interest, and it's taking a long time for them to get all the applications processed. Anyway, you can do it all online. You get a patient number, and then you take that patient number to a doctor, either someone who specifically does cannabis evaluations, or if your doctor does them, then you can do it through them. But it does need to be someone. The idea is that you have like a bona fide, the statute says like a bona fide doctor-patient relationship with. So they're going to need to actually see you in person. This isn't something that can just be done online. They're going to see you in person, do a real H&P, and talk about, hopefully in the best case scenario, actually talk to you about how this may help your therapy. This is kind of funny. I have a patient who was one of the early folks who went to get certified, and she has had surgery from Dr. Henderson before, and she has a lot of fusion in her neck, and she has a lot of things to talk about. justifiably, I think. And so she was speaking with the certifying doctor about getting certified, and the doctor says, "You can stop talking now." I'm there. You don't have to justify it for me anymore. But anyway, it was just sort of funny. But I think there's maybe the point of that is there's maybe like varying qualities of information you can get from the provider, and then also at the dispensary as well. We'll talk in a second about the dispensaries. So you say you want to be a patient, you get a patient number, your provider will activate it, and then you can visit a dispensary. And actually, even before you get a number, or if you're just thinking about it, and I did not know this until recently, you can actually go to the dispensary in Maryland and even go into the room where the stuff is, because I did. There's one near my office that has a registered nurse on staff. And so I went to visit and meet their nurse and talk to them. And I had no idea that you could do, but you have to show your ID, of course, at the front desk, sign in. It was really not that bad. But they will let you go and look and talk, even if you're not certified. And I think that's a good thing to know, because obviously, since it's such a long road for some people to go from that deciding to do it to getting that number, you can go ahead and have at least a little bit of consultation, or see if you think there might be something for them to offer you. Next slide. So there are a number of different ways to deliver medicinal cannabis, and the folks at the dispensary are really going to be your main resource. If you get a provider who's interested in it, they may be able to converse somewhat, but really the specific formulations and even strains will be probably more discussed at the dispensary. I know when I talk to some physicians that have a high level of knowledge in this space, what I do hear is that it may be that the strain concept is overblown, that maybe it's really about those ratios of THC being the hallucinogenic chemical that you hear about, and then CBD being, and there are a lot of different subtypes of CBD, but those ratios maybe of THC to CBD being the key things, and maybe strain being less important. So the ways to deliver the medication would be through edibles. Maryland's statutes don't, and I think this may be changing, somebody may know more about this than me, but initially in Maryland, like, you can't buy a gummy bear, you can't buy significant edibles, you have to basically make your own. I think that is changing, and I should have looked that up before I came to talk to y'all. Topicals are available, salves, lotions, tinctures, etc. There are also patches. And then, of course, delivery via inhalation can be done in a number of ways. Vaping, which just delivers a water vapor, and some patients even will smoke, because combustion actually changes the burning process, actually kind of changes the chemicals, and for some patients that's actually going to be the most effective way, despite all the negatives of smoke. Supposedly there are patients for whom that's going to be their best option. Next slide. So my advice on medicinal cannabis for anyone who is thinking about it would be to seek out a reputable dispensary. Some will have a nurse or a pharmacist on staff. Maryland's legislation does not require that. Some states do, like Pennsylvania does have to have a nurse or a pharmacist on staff. But like I said, some of these ones that are trying to be particularly medically oriented will go that extra mile and have a nurse or a pharmacist available to you. Most of those specific product recommendations are likely to be made by the dispensary itself based on what they offer. I know I've also had patients describe them being able to order certain products, if they have an in-depth consultation and there's a product they don't have in stock, I think there is potential to order certain things. Two more good resources on the web. There's a large website, pretty comprehensive, called leafly.com that goes through various preparations of cannabis, ways to consume it, the strains, etc. Leafly kind of is into the strains. And then healer.com. Healer.com is run by a medical doctor, Dr. Justin Sulak, and he has a really nice website with content about how to use cannabis for different situations, particularly for pain. He has protocols for patients who are trying to wean opioids and try to transition onto medical cannabis. So I think that is one of the more worthwhile resources that I do tend to recommend, particularly to patients. Next slide. So I would say there are all these emerging treatments for pain with ketamine, buprenorphine, medicinal cannabis, and these are all legitimate therapies that may be a good part of your treatment plan, but I would say don't lose sight of the fundamentals that practicing self-care in all these ways by eating a healthful diet is super important. Focus on adding, I like to think about, adding those positives rather than that elimination diet kind of thing works for me. I don't know. Maybe not for everybody. Exercise, find something you can do, swimming, tai chi, restorative yoga, hiking. There may be things you can do and things you can't, but try to find something for exercise. Optimize your sleep, and then incorporating mindfulness techniques or meditation, stress management, relaxation, whatever works for you. I think all of these things will help your outcome with regard to pain as well. Thank you.